Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Thera Therapeutics. My name is Rain Bennett. I am your host. And if you are a regular to the show, you may notice that I have some new digs today. I'm not in my usual home office spot. I'm on the road right now. I'm traveling. And so I have to give a special shout out to Beaufort County Community College in my hometown of Washington, North Carolina. As I'm passing through, they gave me a conference room to have so that I can bring you the show. We're going to do it rain, snow, sleet, anything, we will bring the show to you. So if you are new to the show, what we like to do to start off with is just say hello to everybody and let people know where you're signing on from, where you are in the world. We'd love to see every week where how far this show reaches. It's one of my favorite things about the show. As I said, am currently signing on from Little Washington, North Carolina, the town I grew up in, a town of about 9,000 people. So again, thanks to Beaufort County Community College. Before we get started, we always want to thank Thera Therapeutics, our sponsors. Without them, this show would not happen. And we also always like to say this disclaimer from them, and that is that the opinions expressed by the guests, presenters, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF does not endorse nor promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that last line is really the takeaway. We're going to give you some good advice today. We're going to answer some of your questions, but by no means do we know your specific case. So take that advice, take those answers to your questions back to your home team, which does know your specific case, and make the best plan for you moving forward. So folks, I am very excited about our guest today. We have Dr. Sugandha Dureja coming from, where are you tonight, doctor?
I'm at New Delhi, India.
New Delhi, India. I believe we have had Indian American doctors on before, but this is our first guest, I believe. I don't think it was our first international guest, but definitely from India. So thank you so much for being here. Folks at home, Dr. Dureja, it's what, 9:30 p.m. your time?
Yes.
Okay, so for me, that's bedtime. So we want to send a big thank you to her for being here. Dr. Dureja, tell us a little bit about yourself and the role you fill in this neuroendocrine tumor community.
I'm honored to be here. So I'm a nuclear medicine physician. I work as a consultant at a private hospital, Action Cancer Hospital in Delhi, India. About my journey with neuroendocrine tumors, I was exposed to NETs during my training days when I was doing my residency. We were one of the first hospitals to start gallium imaging. That was way back in 2010. So that's where I got exposed to, got to know more about NETs and NET patients. Gallium imaging was very interesting. After my residency, I went on to do my further training in theranostics or nuclear medicine therapies at the CNETS Center of Excellence at Bad Berka in Germany under Professor Richard Baum, who's a world authority in PRRT. So that was a great opportunity to learn more about PRRT, about managing NETs. It's one of the world's largest PRRT centers, and it was a great learning experience for me. Now, besides those things, I also met there was something interesting. I met a lot of Indian patients there who had traveled all the way for their treatments. That's when I spoke to them, I realized that there's a lot of unmet need for patient guidance and patient advocacy in my part of the world. So it just happened that I got in touch with Grace Goldstein, the CEO of CCF, and she was the one who mentored me and guided me to start our own patient advocacy group in India, CNETS India. So this was in 2013 that Grace guided me, and we started with a patient advocacy group for the Indian subcontinent. We are the only group in India and the Indian subcontinent right now for NET patients. And we're doing some good work and we're growing each year with our NET community. Now, once back in India, I have been doing lots of work with gallium agents, including DOTATOC imaging, Exendin imaging, Pentaxa-4. We've done lots of lutetium therapies. The exciting phase has been the last 4 years when we've started doing alpha therapies with actinium-225. It's been a very exciting phase. We're seeing some very good results. And I'd say I'm as passionate as a nuclear medicine physician as much as a patient advocate.
Love to hear it. And that's one of my favorite things about most of the doctors and the experts that we have on the show is like, it's a passion for people, you know, and and that patient advocacy aspect, I hear that echoed by so many of the doctors we have on, and that just makes me feel so good. And I know that it makes the patients feel good as well. And to your point about Grace Goldstein, I think that she has helped guide a lot of people in this community, myself included. I met Grace in 2011. That's why I'm still here. So big shout out to our COO, Grace Goldstein, who is behind the scenes guiding lots of people in this community. We appreciate you. So for those at home, just to reiterate, Dr. Dureja is a nuclear medicine specialist expert. And so the best questions you'll have, and listen, we talk about these topics all the time, so I know that we're going to get a lot of great questions, but theranostics, imaging, PRRT, alpha therapy, like she just mentioned, these are going to be the best types of questions for you today to get the best value out of. So a couple more things I want to go over before we fully get started, but go ahead and start sending in your questions, especially about those topics we just mentioned. And just know, though, this is the point about the questions. We're going to try our best to get to all of them. Inevitably, we don't. That's a good problem the way I see it, because you all have such good questions, and gives us something that we can keep doing every week. If we don't get to your question, however, I want you to follow up with CCF either here on their Facebook page, or you can go to their website, carcinoid.org. You can send them a private message and they will get you the information that you need. I see everybody signing on. We have people from Canada, all over the States. And I saw Skip said, hi from Atlanta, and thanks for taking my question last week. Absolutely, Skip. I'm glad you're back. And like I said, we're going to try to get to all your questions. But if we don't, follow up with CCF. And also know that as soon as the video is done, it'll be posted here on the Facebook page. It'll live here on the videos tab. You can always refer back to it and watch it again. You can send it to someone else. And starting Monday, we republish it to YouTube for those people who don't have Facebook, okay? There's a couple of things that I ask from you that help me do my job better, which is, of course, to help you. And that's, let's get as many people here as possible. This is the real benefit. Of course, you can watch the show tomorrow, or someone else can, like I just mentioned, but the real value is having the opportunity to get a question across, to have this virtual one-on-one session. So tag somebody in the comments, share the video to their page, let people know that the show is going on now. We'll be here for an hour or just under an hour now, and hopefully they can get their questions across. And secondly, if you see a question that someone else has asked, in the sidebar in the comment section, and you also have that question, or you're interested in that answer, you can choose any of the little love emojis that Facebook gives you the option to. But what that does, they do the same thing. It doesn't matter which reaction you use. It lets me know there's a demand for that question. If I'm scrolling through the questions and I see this question has 7 people who liked it, that means I need to get that question across. So if you can do that, it helps me out tremendously. So thank you. And you all have been doing a great job of that thus far. Finally, before we get started, have you downloaded CCF's free Net Cancer Health Storylines app? This app is awesome. It makes it very easy to record your symptoms, your medications, your nutritional concerns, your moods, all of that. So if you haven't, check it out. We'll put a link in the comment section, and anything that Dr. Dureja mentions today, a resource, an article, a medication, we will also try to put that in the comment section for you, so that you don't have to hop out, open a new tab, go to Google and try to search it yourself. We'll do all that work for you. All right, start sending in your questions. We're going to start taking them soon. So Dr. Dureja, I was taking some notes when you were talking earlier. You were talking about the unmet needs, is the way you put it, of your community, your population. Can you elaborate on that a little bit? Like what were some of those unmet needs that you were seeing when you really like dove into this disease?
Certainly. So when I was at Germany, I saw a very small cross section of the population who could afford traveling so far and paying for treatment, considering that we are low middle income economy. So, and so many patients, from those who could actually make it to the right places, there were so many others who did not even know where to go and what is the correct treatment. So when I came back to India, I realized patients don't know about NETs, there's misdiagnosis, the common problems that most patients face, delayed diagnosis. Patients don't know that although we have such an infrastructure that gallium imaging exists at so many places, but patients don't know that this is what is needed and where it's available. So the availability of resources, the access to resources, plus the major challenge we have in our system of healthcare is, the paying for the healthcare, which is completely non-funded. So we don't have a we don't have a strong insurance system. So yes, financing for treatment becomes a major issue. So these were all issues. These are all issues that we're facing, which are very different from, I would say, the Western world.
Yeah, I imagine.
But we don't have access to these resources for various reasons, unfortunately.
Yeah, those are significant challenges, to say the least. Dr. Dureja, we have lots of questions coming in already, so let's go ahead and start taking some from the audience. Florian, our friend from Germany, says, if a lung net has no or not enough somatostatin receptors for PRRT and somatostatin analogs, is MIBG a good alternative? And are there any other options? And before we take that, let's explain what MIBG is.
So MIBG is meta-idobenzyl guanidine. That's an agent that's used both for imaging and therapy, classically for pheochromocytomas and paragangliomas.
Okay.
I haven't really heard about MIBG being used for, let's say, typical or atypical lung neuroendocrines, besides the POs and the paras. And if you don't have enough somatostatin receptor uptake, there could be some other, a lot would depend on the Ki67 of the tumor, but there could be some options that we could still look for you besides chemotherapy in terms of radionuclide therapies, like, adding chemotherapy to the PRRT, that's called PRCRT, or combined peptide receptor radionuclide therapy with chemotherapy. That will that acts as a radiosensitizer and increases the uptake of the radioactivity in your tumor cells. But then a lot would depend on the specifics of your case.
Got it.
These are just options you could consider.
Got it. Thanks, Florian. I hope that helped. My friend. Next question from Darcy. Darcy says, "What is the what is the level of risk with Ludo Thera and similar nuclear medicine treatments when you have a new metastasis to a bone, specifically?"
The level of risk. Okay, so lutetium therapy is a fairly safe and effective therapy. It's been established in various trials that the therapy is fairly safe. We have a very slight risk of grade 3 or grade 4 toxicities, or something called as myelodysplastic syndrome or leukemia, which occurs in less than 1% of patients who undergo PRRT or lutetium therapies. So in terms of toxicity, it's a fairly well tolerated therapy. There are not any major side effects. If you're talking specifically about bone mets, there's nothing different that you would experience if you had a bone met that underwent lutetium therapy, and it should be effective.
Got it. Thanks for your question. Next question from Dawn. Hi, I've just completed PRRT. Can that treatment be repeated, or is there an F/U therapy recommended or a better treatment? I get this question a lot about can PRRT be revisited?
Okay, thanks for this question. This is a good question.
Mm-hmm.
So we have something called salvage PRRT, in which we re-challenge the patient with PRRT. Once there has been good response to PRRT, PRRT can be repeated after a reasonable period of time, given that rest of the parameters required and the other conditions are fulfilled. As a follow-up, the patient, if even if the patient has progressed on PRRT or the typical lutetium PRRT, alpha therapy with my experience is with actinium, so I would say alpha therapy with actinium may be a good alternative.
Got it. Thank you. Thanks, Dawn. I hope that helped. Moving along, Nelia says, hello, what can be done for mesentery tumor other than surgery? It's pretty large.
Mm-hmm. So, okay. Now the thing is that there's a bit of conflicting data with PRRT for mesenteric tumors. A lot of data suggests that it's not very effective with mesenteric tumors. So you may give a trial of PRRT, or the other options to fall back on, depending on the specifics of the case again, would be targeted chemotherapies.
Got it. Thank you. Folks, it is now 12:15 Eastern time. If you are just joining us or joined us late today, we are with Dr. Sugandha Dureja coming from India. This is Luncheon with the Experts, a Carcinoid Cancer Foundation program. If you all are enjoying it so far and getting a lot of value, say thank you, Dr. Dureja, in the comments. Let her know that you are grateful that she is staying up late to do this show for us tonight. Let's keep the questions going. Next question from Gretchen. Also a common question. Thanks, Gretchen. Are you familiar with the NET test as a liquid biopsy? I've heard that it's more reliable test than chromogranin A. However, I don't believe it's available in the US. Familiar with the NET test?
Well, I think it's available in the US, but not in the place I practice, not in India as yet. So I don't have any real world clinical experience with NET test. I would only be able to speak about it theoretically. So no.
Fair point. I will say, Gretchen, that we had Dr. Irvin Modlin on the very first episode of Luncheon with the Experts, which was well over a year ago at this point, just over a year ago, back in July of 2020. So that whole episode was about the NET test. If you want to go back and revisit that, just go to the videos tab, scroll back to July 9th, 2020, Dr. Irvin Modlin. So you can find out more information. You are not unique with this question. We hear about it pretty much every week or close to every week. And I'll say that it's, I am certainly not an expert, but just from the experience of talking to different doctors and experts about it, I won't say it's controversial, but I'll just say it's a topic of discussion currently. Like some people don't have enough experience to really say a definitive, statement on it, but there is a lot of interest. I will say that it comes up all the time. So hopefully you can see that episode and it'll help you. Appreciate your question. Appreciate you being here. Okay. Next question from Tracy. How many carcinoid patients, we won't have the number here, but this will spawn off a bigger question. How many carcinoid patients have had the COVID vaccination here? Okay. I think this is a question for everybody, but I'm going to ask you a question, doctor. How many carcinoid patients have had the COVID vaccine here, and did anyone have bad reactions? So everybody listening, that's kind of a question for you all. But Dr. Dureja, you and I before we started recording, we're kind of talking about the issues that America is going through, the issues that India is going through with this disease, especially now with the new variants. Let's talk about the vaccine as it pertains to NET patients. A lot of people are concerned. Is this something that is different for NET patients? Should a NET patient still seek it out? And everyone else can comment on their experiences, like in terms of the bad reactions. But what would you say to a NET patient who's like, should I get the vaccine?
You should absolutely go for the vaccine. It will protect you from severe disease. And if at all you contract COVID-19. You'd hopefully be just contracting mild disease. So definitely go ahead with the vaccine. If you're actively taking any therapy or undergoing chemotherapy, please speak to your oncologist.
Got it. That's a good point. Good point to mention. Okay, moving right along from Lisa, when you review gallium scans, there is always a reference to metabolic uptick. Could you explain how you distinguish this from actual tumors? Is it the appearance or the SUV value? Is it possible that other cancers have an SUV?
Okay, so it took me 10 years to learn that.
Yes,
so
perfect. We're going to get that knowledge right here in 10 minutes.
Yeah. So yeah, when we read a scan, we know about where all the physiological distribution, I would say, of the radiopharmaceutical. So there are certain sites where the radiopharmaceutical will go into the body as part of the physiological process. There's metastatin receptors in the body at certain locations in the body, like the spleen, the liver, and it's going to be excreted from the kidneys, the pituitary gland, where this metastatin receptors are expressed, and you would see the DOTANOC uptake there. So as a specialist who reads, any specialist who reads these scans is aware of these sites where you're going to naturally see this uptake, and anything besides that is going to be pathological. So that's how it doesn't really vary with SUVs, but that's how we know the normal biodistribution. So we know what's abnormal.
Got it. Thanks. And thank you for your question, Lisa. Dr. Dureja, next question is not involving nuclear medicine, but I'll ask it and see how you feel about it. Marianne says, anything new found through nutrition or alternative medicine to increase platelets? Thank you.
Alternative medicine
or nutrition
nutrition to increase the platelets. I've frankly not really my expertise, but I've heard about in alternative medicine. I've heard about papaya juice or something being used to increase platelets, but I'm not sure about these areas.
Got it. Okay, thank you. If anybody else has any information, you know what to do. Go ahead and put that in the comments. Next question from Tracy. Is there any recommendations that you can give to increase energy to carcinoid patients? A lot of people have this concern, by the way. Fatigue is a major symptom and problem for me.
Mm-hmm. So I would say as a neuroendocrine tumor patient, it's very important to be under the care of a multidisciplinary team. Your team should have, besides an oncologist, you should be having a net nutritionist or a dietitian who takes care of your dietary requirements, because a lot of net patients, they're very different from each other and they have certain specific dietary requirements. There should be someone to take care of your, tailor a diet for you so that your calorie needs are met and your nutritional needs are met. In terms of the nutrition, I think high protein, calorie dense diet should be able to help you.
Got it. Thank you so much. Next question from Connie. We're moving right along. Connie says, I was diagnosed in 2012 with the neuroendocrine. I was on octreotide and in the past 2 years taking monthly injections of lanreotide. But I was recently diagnosed with classic Hodgkin lymphoma. Is this second cancer typical in your experience or?
Well, not in my experience.
Okay.
I haven't, as far as I know, there's no relation between neuroendocrine tumors, patients developing a lymphoma, either related to each other or due to therapy. So I would say no, this has to be a sporadic or an incidental thing for you, unfortunately.
Thanks, Connie. Sorry to hear that. And please stick around if you have any other questions. Let us know. We'll try to get to them. So Jesse has a question or a request rather, and Jesse, you took the words right out of my mouth. I make little notes over here on the side. I wanted to bring this up as well. Jesse simply says, please talk about alpha therapy. And I had already made a note. I know we've mentioned it a few times already today, but I had made a note just because I know that this is a topic of interest, of discussion. Let's lay some groundwork, right? Let's explain to the people like what exactly it is and what are the potential benefits that it holds. Like let's give the 101 of alpha therapy.
Right. So I have experience with actinium-225 and bismuth 213, which are the two alpha emitters. A very brief experience with bismuth, so I'll be talking more about actinium-225. Basically, let me start from where I think most people would know, with lutetium or therapy. So lutetium, the radioactive molecule used in PRRT typically is a beta emitter. So it emits beta radiation. Now, with alpha, actinium, it emits alpha radiation. So alpha has an advantage over beta because it has a higher energy. It travels a lower path. So both these two factors give it the advantage. Because of the higher energy, it's going to cause more damage onto the tumor cells. And due to the smaller path length, it's going to cause lesser damage to the surrounding normal tissue, which translates into lesser side effects. So the principle of therapy remains the same. It's also a PRRT, a type of PRRT. So the same concept of going and binding to the somatostatin receptors. But when we use the alpha emitter actinium, it is a stronger radiopharmaceutical. It is going to cause more damage to the tumor cells, and which will cause more injury to the tumor cells and a higher chance of death to the tumor cells. It's called apoptosis, and which is eventually going to show up on your scan as tumor shrinkage, better tumor shrinkage. So briefly, that's the advantage of actinium or alpha therapy.
Got it. And as I'm scrolling through the questions, I see other people like, please discuss alpha therapy. So I'm glad that we got that across. But everybody, if you have follow-up questions about that, if you need clarification, let us know. That is what we're here to do today. Next question from Karen. Karen says, what is generally the most effective treatment for low-grade receptor negative NETs that behave more like high-grade? You follow that?
Low-grade receptor negative neuroendocrine. Yeah,
correct. Yes. That behave more like a high-grade.
Right. So if you are receptor negative, that absolutely precludes peptide receptor-based therapies for you. So you have other options available like chemotherapeutic agents, CAPTEM, and other targeted chemotherapies, which you can proceed to. These are more helpful for high-grade neuroendocrine tumors. And there's more and more work happening. I believe there's immunotherapy coming into the landscape now for high-grade NETs. So yes, a lot of options are there. But not PRRT, unfortunately.
This is a question from Karen that says, a lot of us have been getting small red bumps on skin, different areas of the body. Is that something normal that could be happening from the cancer, or maybe from octreotide or lanreotide? There's a few people that have liked this. So like, have you ever heard of that?
You know, small red bumps is a slightly vague thing to diagnose. And
tell us exactly what it is. For everybody at home, this is a great opportunity to kind of like share your own experiences. I think one of the best parts about the show, I always see it as a kind of like twofold. Like we present a lot of information, and then we present the community aspect of it. Like the community that we have kind of cultivated here at Luncheon with the Experts, I think is just as valuable. And that means sharing your own stories and own experiences back with and forth with each other. So I think, you know, I had mentioned earlier with the vaccine, and I see you all chiming in about that. This is another opportunity to share your experience if you've had something like that. I saw 3 people like that question, so I'm assuming that means that you have or do? And if so, let Karen know. Next question from Jesse: for lymph node metastasis, is there a best course of treatment generally?
Okay, so I would just I would need more details about what is your primary, what is the grade of your tumor. But if you're having a metastatic NET, is what I would broadly understand from your question. If it's already a metastatic disease that is inoperable, you would probably need to proceed to sandostatin therapy as a first line and then go ahead with that. But this is just a very broad outline based on the limited information you've asked.
Got it. Thank you. Yeah, and folks, that goes for everybody. If you have other information, you know, if we can't completely answer your question, or if you have follow-ups, like as long as you're still here, go ahead and keep putting the questions in the comment section. I'm going to try my best to get to them. And I will remind you and reiterate, if we don't, please follow up with CCF, either here on the Facebook page. You can send them a private message, or you can reach them at their website and email them at carcinoid.org. Either way, they're going to work very hard to get you the information you need. Either they will provide you the information, or they will provide you with the person who can get you the information. So I really, really encourage you to do that. Lewis says, how often and at what intervals should one get PRRT for the best effectiveness? If it seems to work the first treatment. Okay, so if it seems to work the first treatment, how often and at what intervals should one get PRRT for the best effectiveness?
So the averagely acceptable interval is about 8 weeks, or maybe plus or minus 1 week if at all needed. So the average interval is 8 weeks, and the standard would be about 4 therapies at one go. But then depending on the need or the response, we can do more therapies. At my institution, we depend a lot on dosimetry, and we use dosimetry to determine the further course of therapy and to customize and tailor the doses for each patient. So that's absolutely personalized therapy. And so that's how we decide if the patient it's safe enough to give more therapy or not.
Got it. Thanks, Lewis. Appreciate your question. Oh, and we have a follow-up from Lisa. Great job, Lisa. This is exactly what I'm requesting that you all do. Follow up on her gallium scan question earlier. She said Dr. Dureja didn't address whether other cancers have an SUV, such as in the abdomen, colon cancers, reproductive or ovarian cancer. And also before this, what is an SUV?
The SUV is standardized uptake value, which is calculated typically on a PET scan for almost all radiotracers that we use for different scans, like FDG or Gallium DOTANOC PET scans. So I'm sorry, could you just repeat what exactly is she asking?
Well, she had asked a previous question, but then this is, do other cancers have an SUV, like colon cancer, ovarian cancer? Do they also have SUV, or is it just NETs?
Oh, on the gallium imaging? No. So gallium imaging is, it is based on the premise that only tissues or tumors which express the somatostatin receptors will light up on gallium imaging. So other cancers like the typical adenocarcinomas of the ovary or the adenocarcinomas of the colon or any other sites will not usually express somatostatin receptors, so they will not light up on gallium imaging.
Perfect. That was the question. Thanks, Lisa. Hope that helped. From Maryland, is alpha therapy available for patients who have already had Ludo treatment?
Okay. Yeah, that's a fairly common question I come across. So yes, the answer is yes. Patients who have had lutetium therapy, as long as the blood parameters and the renal parameters are stable, there's no issue about going ahead with alpha therapy. In fact, we've used alpha therapy in patients who progress on beta therapy, on lutetium based beta therapy. So it's a step ahead. Even if you progress on PRRT, alpha is, let's say, a step further, another weapon in the armamentarium to target the tumor again.
Got it. Thanks, Marilyn. Another question in the same vein from Eliana. Is Alpha PRRT therapy an approved treatment for NETs in Europe or India, or is it in clinical trial stage only at this time?
Okay. So in India and in Europe, both, we're using alpha therapy for about 4 or 5 years now. And it is used not under a clinical trial setting, but as a regular clinical therapy under the purview of compassionate use for patients with progressive NETs who run out of other options. So this is not under any trial, but under a regular clinical therapy for compassionate use.
Got it. All right. Thanks so much for your question, Eliana. Hope I'm pronouncing that correctly. Let me know if I'm not. Sharon says, are most treatments for NETs dependent on having receptors? If you lack them, does it mean your tumors are too small? And also, if that's the case, what treatments are available to you?
Okay. So usually, we divide neuroendocrine tumors into three grades, grade 1, 2, and 3. So in our experience, so we've seen patients, usually patients with grade 1, and I would say most of the early grade 2 patients express the neuroendocrine, the somatostatin receptors. It is with the higher grade tumors, which are also known as the high-grade NETs or the NECs, neuroendocrine carcinomas, both of them, they usually do not express much of somatostatin receptor. So this does not mean that you do not have any therapies for these patients. These patients only are, I would say, less eligible or ineligible for PRRT, because PRRT depends on the expression of somatostatin receptors. There are, of course, many other therapies for patients with high-grade NETs, but the mainstay of therapy would be chemotherapeutic agents.
Got it. All right. Thanks, Sharon. Appreciate your question. Okay, from Marilyn, another question about Ludo. If you've had 3 Ludo treatments and missed the 4th one due to a blockage, when there's future tumor growth, can you get 3 more treatments or any more treatments?
It is not very clear to me of what blockage we're talking about.
Yeah, nor me. Marilyn, if you have any clarity on that, let us know. It just says due to a blockage. And then I guess the question is, when there's future tumor growth, can you get more treatments? So I get like. Okay,
so I'm just going to try to answer it broadly.
Yeah.
So in case, let me presume this blockage was in the bowel, or maybe in the bowel. So in case it has been caused due to the PRRT, the Ludo treatment, it would be probably not be advisable to go again for this therapy. But in case it's an incidental thing that happened during your course of your Ludo treatment and it gets resolved, you may go again for your Ludo cycles.
Got it. Hey, thanks, Marilyn. And if you're still around, let us know if there's a little bit more information on the blockage to make sure that we were answering that appropriately. But also, I see your second question, Marilyn, here, so I'm going to ask that as well. If you were getting a gallium scan, will you see something different than you would see on an MRI? So essentially, like, what's the difference in the two?
Okay, so that's a good one too. So a gallium scan is it's a PET CT. So it's going to have a gallium receptor. It's going to show you the anatomical information from the CT scan part of it and the the somatostatin receptor status from the gallium radiopharmaceutical part. So it's going to give you a mixed fused image with both information from both the functional part, the somatostatin receptors, as well as the anatomical information from a CT scan. Whereas an MRI is going to give you anatomical information, certainly better than a CT scan from the gallium PET CT, but then the uses of both of these are slightly different.
Got it. Thanks, Marilyn. Okay, in the same vein, Erica says, gallium scan pre-surgery, an appendix tumor and one lymph node did not show up. Post-surgical gallium scan, all clean. What gives? Why did my tumor and lymph node not originally light up? What would cause that to happen or not happen, rather?
Okay, right. So there can be many causes for a tumor not lighting up on a gallium scan. First, if the tumor size is very small, it will not take up enough radio tracer and not light up or show uptake on the gallium scan. Secondly, if your tumor is not expressing enough somatostatin receptors, so if it's somatostatin receptor negative, or if it is a higher grade tumor, it is not going to show up on a gallium scan. So these are the basically the two reasons where, the commonest two reasons where your tumor may not light up on a gallium scan.
Okay, thank you. All right, next question. This is from Rebecca. Do NETs always eventually go to the liver and or pancreas? Is there something that we can do to keep it from going to the liver or pancreas? So first of all, does that always happen or typically happen? And is there anything that can be done to prevent it if so?
Okay, thank you for the question, Rebecca. So liver metastases are most commonly seen with mid-gut neuroendocrine tumors. They are a little uncommon with the rest of the other sites of primary neuroendocrine tumors. But, I would come back to the same thing. To prevent liver metastasis, you need to diagnose the tumor early, treat it early. So if you have an early diagnosis and start treatment early, you'd probably not, end up with liver metastases. Pancreas usually is very uncommonly involved in metastatic disease. More common is a pancreatic primary neuroendocrine tumor.
Got it. Hey, so Dr. Dureja, I just heard back from Marilyn with the blockage question and the PRRT, 3 rounds. And she says intestinal blockage, which was cleared with surgery. Okay.
Yeah, right.
Okay, so next question from Debbie. And there's a little bit of information here, so bear with me. I was diagnosed with ileal CC 17 years ago. This was resected, but now I have 60 diseased nodules or nodes causing me digestive issues. My biopsy 17 years ago showed 1%. They are currently looking into PRRT to shrink the tumors to make it operable or make them operable. I have had a scan show that I have the necessary uptake. Does this sound possible to you?
Yes, it does. So there is a known role for neoadjuvant, if we call it that way, just like we have neoadjuvant chemotherapy for a surgery, we have neoadjuvant PRRT before, PRRT helps in making a tumor amenable to surgery. So we can shrink the tumor a little bit and make it operable. So yes, there is a role of neoadjuvant PRRT in certain cases.
All right. Got it. Thanks, Debbie. I hope that helped. Next question from Andrew. Andrew says, if I have a grade 2 tumor and KI 67 at 17% and no spread, if I get a future tumor, would it be a similar grade?
Right. So usually the Ki-67 hovers around the same value, but having said that, we see a lot of tumor heterogeneity in neuroendocrine tumors in many patients, which means tumors in various parts of your body in the same person may have different Ki-67 values, which happens with time in many patients, right? So yes, it should be more or less the Ki-67 in the other sites of disease should be near about the same, but there may be, if there's tumor heterogeneity, there may be a wide variability in the Ki-67 of the tumors.
Got it. Thank you. And thank you for your question, Andrew. Folks, we have just about 15 minutes left with Dr. Dureja. So keep sending your questions in. We're going to keep churning through them. We appreciate you being here. Dr. Dureja, we talked earlier in the beginning of the show about how important patient advocacy is to you and your practice. So I have a question. What can a patient do, in your opinion, to be their own best advocate? What are the things that they can do if they were diagnosed with this disease to advocate for themselves?
Okay, that's a lovely question. Thank you for this question. So I am a big believer of patient advocacy and patient equality, patient involvement in the treatment, the entire spectrum of treatment of the whole journey of treatment. So I think for patients to be equal partners in this journey, they should try to educate themselves, collect reliable information about the disease, so that they're able to discuss better with their physicians. They're able to make informed decisions regarding the course of their treatments and therapies. I believe patient support groups, patient advocacy groups like CCF have a huge role. They make a huge difference, because you guys are doing great work in providing reliable and solid information to the patient community. It really guides the patients to reliable information, which will eventually help them become equal partners in their care.
Yeah. And I think with this disease, that's vital, because each case is so unique. So thank you so much for answering that, folks. Like I said, we got about just shy of 15 minutes. We're going to keep going. Gretchen says, does PRRT decrease platelets as much as other chemo treatments?
Okay, thank you for this question. No, PRRT is usually not seen to decrease your platelet counts. There is a very slight and a very transient hematological, or let's say marrow toxicity, which happens, grade 1 or grade 2 toxicity, and it recovers on its own. There are very, very few patients, I would say less than 5%, who would actually need support in the form of platelet or blood transfusions following side effects from PRRT. So it's very safe. You will usually not get any platelet dips following PRRT.
Got it. Thanks for that answer. And next question is from Bonita. Bonita says, is there another scan that should be done if nothing is showing up on the gallium scan, but there are indicators in the blood? So how would you determine if there is a receptor negative or a high-grade tumor?
Okay. So like we discussed a little while ago, these metastatin receptors are expressed mostly in low-grade tumors, in grade 1 and early grade 2 tumors. The higher grade tumors usually do not express these metastatin receptors, so they're not going to light up on a gallium scan. These are the patients where we use the standard FDG PET scan, which is the workhorse of all oncology imaging. So the FDG PET will show up the high-grade tumors. Besides, this is maybe very, very specific to insulinomas. Besides gallium DOTATOC, we also have gallium exendin imaging, just specifically for insulinomas. So this is not for all the general neuroendocrine tumors, but I must mention this is only for insulinomas, which do not light up on a gallium DOTA PET. Gallium exendin PET may be a better imaging for that to pick up an insulinoma. But usually talking about the standard high-grade tumors, FDG PET is probably definitely needed for imaging a high-grade neuroendocrine if the gallium imaging is negative.
Got it. Thank you so much. All right, we're still going to keep going. Jesse, another great question from Jesse. How can you tell if the disease is metastatic or if there are multiple primary tumors? So first of all, can there be multiple primary tumors? And then if so, how do you tell between those two options?
Okay, so it is very, very uncommon to have multiple primary tumors. I have not seen such as in multiple primary neuroendocrine tumors. I've seen multiple primary in other cancers in many patients, but not in neuroendocrine, as in 2 or 3 sites of primary tumors. So by the characteristics on imaging, by your pathology characteristics, by your immunohistochemistry, we usually are able to fairly certainly identify the primary site of tumor. And on imaging, if we are seeing any other sites of involvement, they're usually the secondary or the metastatic sites. So that's how usually the scenario is.
Got it. All right, next question from Bernie. Is there a percentage of NETs which will not be affected by the PRRT treatment? It's a broad question.
Yeah. So yes, one prerequisite for responding to PRRT is the presence of somatostatin receptors, but there are certain other factors too, like very individual factors like your disease burden, your metastatic disease status, the sites of involvement, the organs of involvement, which will also determine the kind of response a patient would have to PRRT. So it's going to be very, very individual and dependent on the condition of your disease. So patients who have high-grade tumor are lesser likely to respond to PRRT, and patients at times may not respond to PRRT with lutetium due to many of these, underlying factors. But then that has to be very, very, depends a lot on the individual conditions.
Absolutely. Thank you for that. Question from Andrew. Is there any science, to your knowledge, to avoiding sugar, gluten, lactose, or any other foods to tumor growth? And I know this isn't nuclear medicine, and we've kind of talked about nutrition already, but these questions do come up a lot, especially the sugar one. That's a big one. Like, yes. does sugar, basically feed tumors? But also anything, any of these foods that we deem bad, gluten, lactose, a lot of these things that people have intolerances to. Any thoughts on that?
So I've faced this question a lot of times,
right.
Talking to the patient community. Well, there's no scientific evidence about avoiding sugar because in terms of tumor growth, or avoiding sugar to avoid the tumor growth, because the body in any case will produce its own sugars itself, even if you don't feed it sugar from outside. So these are all scientifically unproven things. Having said that, a lot of neuroendocrine tumor patients do have certain dietary conditions, dietary restrictions in terms of patients who have carcinoid syndrome. They have certain foods which trigger their carcinoid syndrome. So for those patients, a lot of them may be avoiding lactose, avoiding gluten, depending on the need in terms of your, the aggravation of the carcinoid syndrome may be a good idea, but then that has to be, really discussed with your treating teams and those, and has to be documented once it's documented that you have allergy, or let's say your carcinoid syndrome is aggravated by certain foods, it may be a good idea to avoid those foods, but not in terms of any scientific explanation in a broad way.
Got it. I have, I think, a follow-up question from Karen, who says, is it safe to have, this is again about the COVID-19 vaccine, is it safe to have a Gallium-68 scan with the COVID-19 vaccine or at or around the same time? Or is there any reason to be concerned with that?
Well, I would not think there's any reason to be concerned with that. On FDG PET scans, we are seeing some, post-vaccination lymph nodes lighting up, but I would not expect any such kind of, confounding issues with a Gallium PET scan. So I think it's absolutely safe to go ahead with your vaccination and your scanning.
Got it. Thank you. Next question from Effie, who's a top fan. Good to see you, Effie. I don't think I've heard from you today, but good to see you back at the show. How do you manage when scan reports state something is unchanged, yet the first time it is reported on the scan? Why is that? Does that make sense?
So are they trying to say that it's reported for the first time, but it remains unchanged?
When scan report states something is unchanged, yet that is the first time it is reported. Okay. How do you manage when the scan reports states that something is unchanged, yet that is the first time it is reported on a scan? Why is this?
Right. So the only plausible explanation I can think of is probably someone missed reporting the findings the previous time, and the next time they just mentioned it and said it's unchanged. So it was probably missed to be reported last time, but it remains unchanged. So it's not, maybe that's the, I think that's the essence of the question.
Okay. And hey, Effie, if I misrepresented that question and you're still here, let me know. Give me a little clarification. I want to make sure that we get this across, because also 5 other people have liked that. So let me know if there's an additional piece of that question. Moving forward, Dr. Dureja, looking into the future, what are some things in your field specifically that either you're hopeful for, that you're looking forward to in terms of treating this disease?
Okay, I'm a very optimistic person. I'm actually hoping for better and better therapies, and probably one day cure for neuroendocrine tumors. But from the bottom of my heart, I would say I would earnestly wish for an early diagnosis for more and more patients, so that we catch the disease early, we can treat it, cure it. There's a higher chance of cure when you catch the disease early. In terms of my specialty, I think we're getting more and more newer imaging agents. We're getting more and better therapeutic agents like alpha therapy. We're getting combination therapies of PRRT with radiotherapy. It's called Combi Earth, with that's combination of PRRT and external radiotherapy, external beam radiotherapy. We're getting sandwich PRRT, something called a sandwich PRRT, which is PRRT followed by oral CAPTEM chemotherapy and another PRRT. So we sandwich the CAPTEM between 2 PRRT cycles. That may help even slightly higher grade of neuroendocrine tumor patients beyond grade 2 too. So we have the NETTER-2 trial coming up, which should hopefully open the doors for PRRT for higher grade patients. What we look forward to now also is understanding the sequence of therapies for neuroendocrine tumor patients, how and what should come for each, because neuroendocrines are very, very very heterogeneous and each patient is different. But then we are certainly working towards finding a certain broad sequencing of treatments. We're looking for more and more prospective data in favor of PRRT. So there's a lot of exciting things happening and coming up. And let's just hope that it all works out all the more better for the NET community.
Absolutely. And I'm glad to hear that you are so hopeful for the future. And I hope that that helps give you hope. Folks in the audience, we thank you for attending. That's our show for today. I just want to say, Dr. Dureja, it's a few great comments here at the end, but Bernie says, thank you so much. Your answers are very helpful in understanding this disease and treatment options. And I couldn't agree more. So Dr. Dureja, thank you so much again for making the time. I know it's late in your part of the world. Sincerely, we are grateful for your time today.
It's been great being here. It's been a pleasure. Thank you so much. I really enjoyed interacting with you.
Yeah, that's great. That's great to hear. And thank you all at home again, as always, for joining us. We hope that this show helped answer some of your questions. And I'll reiterate one more time, reach out to CCF either at carcinoid.org or here. You can private message them at the Facebook page if you have follow-up questions or any information that you are still seeking. As always, thanks again to our presenting sponsor, Thera Therapeutics. We could not do this program without them. And finally, my name is Raymond Bennett. I have been your host. Thank you for watching and join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.